Welcome back, and that's the latest in the world of sports. Let's go back to the big conversation of the day, all to do with the state of healthcare in the country. We're still joined by the Health Cabinet Secretary, Dr. Deborah Barasa, in studio. Thank you so much for your patience. Overwhelming questions coming in. But before we get to the questions, and we have to urge our viewers, continue sending them on our toll-free number 22151. We have to talk about the state of human resource in healthcare in the country, because it's an important component if we are truly to achieve TIFA care. The doctors under the Union KMPDU have hinted that they might be going back to the streets, an unprecedented second time in 1 year. It's quite unfortunate. And if you hear from the doctors, they mention that the return to work formula is the bone of contention, that perhaps government hasn't been true to its word. They give a couple of days, 21 days. Are conversations ongoing? What's the status, especially for Kenyans who want to know if they'll be facing challenges as they faced earlier on for over 50 days?
Yes. So first of all, what I'd like to say, we appreciate the great work. I have been an intern. I know the great work that goes on during internship. The 365 days of internship are intense. It involves you, staying, long hours, conducting surgical procedures, going to the wards, and so on. It is a learning time. It is a time for, undergoing mentorship, again, supportive supervision from our seniors. But again, it is a time when you understand how to run a ward, how to run a facility. So it is critical. And I believe that we, even in the medical profession, and even the nursing and the clinical officers, they know how critical this time it is, because it builds on our skills, it builds on our expertise, and again, it helps us understand how we are going to grow career-wise. It gives us a path on our career, even as we engage and interact in various of these platforms. And so we are in support. We know that the interns are fast on call. We know that the interns are greatly involved in terms of management of cases. The 365 days of transition are really critical. We know that you go through training, you get your degree in clinical and surgery, clinical medicine or medicine and surgery, and then you have a transition of 1 year, which is 365 days, before you get your license as a medical practitioner, and that is when now you can start practicing. So that transition of 365 days is really critical, and so we acknowledge the work that you're doing. But again, we really need to look, and what we are doing with them is we are negotiating with the interns, the KMPDU, to really come up with a solution, and again look at sustainable solutions, because these are essential services, and since they're essential services, we cannot have routine strikes within the Ministry of Health, and especially for the healthcare workers. So we are negotiating, we are engaging to see what are the sustainable solutions. But my advice to the interns, even as the negotiations continue, these are 365 days of your mentorship, supportive supervision before receiving your license as a medical practitioner. And so it is a time for you to engage and learn more, even as you think about your career growth or moving forward to become a licensed medical practitioner. And so it's important that they view this as a bigger picture. We will engage. I don't think there'll be any disappointment within our engagement. Yes, I am conflicted, of course. I will support my people. But again, I want the human resource, not only for the medical practitioners, but also for the clinical officers, the nurses, and other human resource for health. We need to have sustainable solutions. And again, we are tasking the public service component. How do we harmonize the salaries of various, public servants to ensure that, others do not feel discriminated, that one is just coming recently and earns, 4 times or 5 times the salary. And I think they need to really take it up and harmonize and do, routine 5-yearly or 4-yearly review of the whole, human resource capacity, so that we don't have a few feeling discriminated, or based on their negotiation capacity, they get a better deal than others. It's really good that we harmonize all this and we are really at the same platform.
Madam Sis, I have to press you on that matter.
Yes.
So you've talked about engagements and we hope they yield results. Is there any white smoke as we see it right now? Can you tell Kenyans that come, is it 23rd, there'll be no strike because we're doing 1, 2, 3? Can we give practical examples perhaps?
Yes, we are negotiating, we are engaging, absolutely. I am engaging them, and also my team. We have a core team that is routinely meeting them, and we are keeping abreast of the concerns. Equally, we are meeting with the Treasury to ensure that resources are mobilized promptly. So it is nothing, it's something that I hold dear to my heart. And the human resource for health, clinical officers, nurses, doctors, everyone, the physiotherapists, psychotherapists, we need to ensure that they have quality, of life, quality and a well-being, and also look at the mental wellness component for them to work seamlessly. But for the interns, again, I'll still emphasize they are around 1,000. It is a transition. It is 365. You are working, undergoing mentorship, supportive supervision before you get your license as a medical practitioner.
Has money hit the accounts?
The money should have hit the accounts by now. Yeah, for the interns, yes. Yeah.
For the 4 months.
That is the 965 million, right?
Sorry?
For the 4 months, 965
for the 4
million
months. Now, what we are doing is negotiating to see if we will have the top up of the rest of the money. And I believe we will come up with a solution for interns, okay? And then we need to come up with a sustainable solution so that we don't have routine strikes.
Okay. All right, let's move on to some of the questions that are being asked. And would you like, if you were practicing, or is it convenient now while on the other side? Imagine it on, you being on the other side. How would you have handled it? How would you have felt?
Yes. So, there are 2 different components. When you work in the management, for me, yes, I worked as an intern. I've grown into the medical practice, into becoming a physician, and again as an infectious disease expert. So I have had, again, the public health component with the World Health Organization, and then now in the Ministry of Health. So my mindset is broader, because we don't just think of the intern, we need to think of the whole system. And that's why UHC is a paradigm shift. It's all about the human resource for health. How do we ensure that there's quality for each human resource for health? Yeah, so that no one is feeling undermined or discriminated, so that everyone has an appropriate career path, so that we are addressing mental health concerns, yeah, and especially career growth for the interns, for the doctors, for the clinical officers, etc. So for me, it's a bigger picture in where I am right now, so that we have affordable, accessible, quality care, and we have good career paths for our human resource for health, or our healthcare workers.
Okay.
Yes.
All right. Another question coming your way here is that the president did say that he will pay for Kenyans unable to make monthly share contribution. How many Kenyans is the government paying for so far at this particular moment?
So far we have 2 million under the National Social Protection from the Secretariat. They have a registry of 2 million. So we are integrating that, the same 2 million in the Social Health Authority. Yet again, we are also conducting assessment using some harmonized tools, proxy means testing, and also community validation of the status of individuals. And if we notice that they are vulnerable, they are needy in the community, then they are paid for by the sham. Again, we look at the refugees where they're being supported by UNHCR, and Linda Mama is again supporting the needy mothers or mothers who are unable to pay when they come for delivery. We are engaging other donors to also support us to onboard even more of the orphan, the vulnerable, the needy in our community, so that no one is left behind and everyone can access the very services that we are talking about.
Right, more questions here. There's one who asks, when will the oncology package for primary screening in the SHA shift be affected? Can a woman go for HPV test and be covered?
Yeah, that's a good point, and definitely we are looking to strengthen that. As you can see, we are less than 100 days old. We are reviewing the benefit package. We are ensuring that we are, sending these health products and technology to the last mile. So gradually you'll see the benefit package improving, and gradually you'll see that the services will even become better. So we are working on that. We don't have clear time, the timeline, but we believe within 6 months to 1 year we should have the screening also incorporated.
Another one here, why am I paying 1,030 to shift, yet it should be 300, Bob?
Yes. So if in case you are not comfortable with that, then just contest and we will look into it.
It's that simple?
Yes.
And how long will that process take? Because most of the time, it's the period that process takes that it's so tiresome for Kenyans.
Yes, no, we want to ensure we'll be monitoring the turnaround time, but what it will involve is for someone to come and validate to ensure that the concerns are really, in synchrony with what someone has shared.
And as you mentioned earlier, it's only 2% of Kenyans who have appealed.
So we are,
yeah.
Because the average is 575 Kenya shillings. We've not had many people appealing so far.
Okay.
Yeah.
Okay.
Shall we have something equivalent to comprehensive insurance for civil servants?
Yes, we will. We'll have a medical scheme for them.
Okay, Jesse.
Yes.
Have we reverted back to NHIF system? I asked that question a little bit earlier. We didn't get a clear answer, but still on the human resource component, so many questions are coming in on the ministry's plan on the UHC contracted healthcare workers. Are there any plans to absorb them into PNP, matters gratuity and whatnot? Those two questions, yeah.
So for the UHC staff, they are now housed at national, but they work at county level. So, health is devolved. Human resource, the big component that is, conducting service delivery is devolved. So they're at county level. So some of the counties have been gracious enough to onboard, and we are still working to ensure the others are also taken up as permanent and pensionable. So for us, there is really a county concern, so the engagement is at county level.
Okay.
Yeah.
NHIF systems?
NHIF system, yes. So we need to really look at NHIF and what we are saying for Taifa Care compared to NHIF, affordable, accessible, quality care. And in affordability, even you can see from the values we are seeing. And when we talk about accessibility, what are we saying? We are leaving no one behind. And that's why you're seeing we're also looking at the vulnerable, the needy in the community to see that they are on board. Again, we are looking at the issues of service delivery. Okay, so that we are looking at the benefit package and gradually improving it to suit the community. So the previous one was based on research, NHIF, the services that they were offered based on the prevalence of diseases, what caused people to die, what are the catastrophic expenditures, etc. But now we are coming and we are now, because we are saying we are people-centric, we are looking to ensure that Kenyans receive the utmost quality of services, and we are looking at their needs. Okay. So we will look again to capacity, and that was not again in NHIF. Equally, the coverage, as I said earlier, 33% for NHIF. Now we are at 66%. We look to even have a broader coverage, both geographically and again in terms of the population, the number of people, so that everyone can access care. Again, the health products and technology, and this is through the FIF Act, where we are saying that for each facility, let us register, people, let us see people under SHA, and the money can come to the facility. And gradually, as the money keeps increasing, then we can have products, medical supplies, we can have, equipments, and even human resource. So you can see that the capacitating is not just limited to those facilities that were in NHIF, but it's general. Once one has contracted, then your facility can be capacitated and you can render the services. The digital health platform, again, turnaround time, efficiency, transparency, and looking at the other components like of claims. We are really having better systems under SHA as opposed to NHIF. So we are not looking behind.
Okay. All right. CS, earlier on, you talked about the fact that Linda Mama is supposed to cater for the needy mothers. Here, we have one viewer who is asking, is Linda Mama operational? I took my neighbor for delivery and she was told to pay an upfront of 7,200 shillings, yet she's registered with SHA.
Yeah, so Linda Mama is there. For any woman who is needy, a vulnerable woman who needs support in terms of the services under Linda Mama, yes, they can. Okay? So the challenge before was the communication, but we have addressed, even for teenage pregnancies, they can also get services under Linda Mama. So the concept of Linda Mama has changed. Linda Mama previously would pay for your delivery. Actually, they used to pay 2,500 for normal and 5,000 for a C-section. Now, for a C-section, it would go up to 20 or 30,000. So the facility was actually at times going at a loss, you see. But whatever they could get, then they could utilize it. But now we are saying, under SHAM, a C-section is going for 32,000. So the facility is benefiting and the mother is also benefiting. If the mother says, I cannot pay, then we pay for her premiums for herself and her household. So her maybe unborn child or the newborn child, and even for her husband and her children. Okay. So the cover is even better because it's family oriented. It's not just an individual person. The covering is much, much better. And so we need to encourage. I think the challenge was communication, and we are working with the people involved in maternal care to ensure that mothers are onboarded and they're
So how do they get to that premium? They have to register?
Yes, they have to register. We have an eligibility criteria under SHA. And also if they do the means testing and they are found to be needy, then they can benefit, okay? Again, if they can inform the healthcare provider that they are unable to pay, we cannot send a mother home. We are really working towards improving, the maternal care and reducing maternal deaths in Kenya. And we are coming up with various interventions, including delivery of mothers, prompt delivery through the emergency, an emergency fund, and again ensuring that Linda Mama is working. So, yes.
So teenage mothers can actually register with their birth certificate.
They can register, or they have unique identifiers. If you don't have your birth certificate, you will receive a unique identifier, then you will have access to all the services that you require. Okay,
we'll have to give you a chance to give your part in short, but as you do so, address these teething problems, because we've equally received some comments that point to the systemic challenges, and not just those who are seeking services from healthcare facilities. Those who are equally offering services are pointing out that, hey, we need to improve this system. So speak to the realities of what the ministry is doing to enhance all these issues as you give us your parting shot here.
Yes, we are addressing them. Definitely, we are ensuring that the system works well. It was a new system. It was launched nationally. And so, yes, But I believe the challenges are gradually reducing. They are not as they were during the 1st of October, the first week of October. And so just let us trust the process and just support us through this process. Your concerns, your challenges are fundamental. They are critical for the success of Taifa Care. And so we don't take it for granted. We will ensure that the concerns are addressed. The human resource for health, the interns' concerns, the health products and technology, digital health platform, as well as the social health insurance fund. So let us engage. We'll take up all the questions. Please send as many as possible. We want to ensure that we are gradually improving this system so that by the time, sometimes they say you're a liar, I don't know what, but it's less than 100 days. What we are looking at is really working together, collaborating with the support groups, the stakeholders, the community, the political elite, the human resource for health to ensure that this system works well. And it takes all of us, to collaborate and to synergize our efforts. It's not just one person, but it's the whole thing, because it's really a health system paradigm shift. It is for us to work together. And so my parting shot for all Kenyans, I am asking you that you register and contribute based on your financial capacity. I'm also requesting for our healthcare workers. You are a critical pillar for health. And so let us offer health care services that are of quality. I believe in Kenya we can offer international standard quality services, and we should really work towards that. I also want to talk to the healthcare providers, and what we are saying, let us contract and let us offer services under Social Health Authority. And for political elite, we ask you that be champions, be advocates of Taifa Care. And again, for our developing and implementing partners, support us during this noble cause, whether it's adopting a child and supporting them through paying of their premiums or supporting a program. It is really critical at this time of transition so that we ensure that we have a seamless transition and Kenyans are well. And so, again, I would like to tell all of us, Taifa Care, afya yangu, haki yangu, lakini jukumu langu pia. Sasa tujisajilishe. Let us register for SHA. And for the Ministry of Health, we are leaving no one behind. Let us work together and collaborate to make Taifa Care a reality.
Finally, one more question, Madam CS. Yes. You've been in office for what, 4 months thereabout? Yes. How is the heat at Afya House? Yes, it is challenging. It's very challenging, but from my journey, right from internship, through working in the various, I've worked in the slums of Nairobi, I've worked in the Kenyatta National Referral Hospital, I have worked with various partners across the globe, I've worked at WHO level, I've worked in various countries, including Nigeria, South Africa, Malawi, Zambia, name it. Yeah, especially in Eastern Southern Africa. I think I've been able to visit various countries. Within the continent, I can say around 22. I have seen various health systems. And so being given an opportunity to implement UHC is a privilege for me. And for me, I want this thing to work, because I know I've met the vulnerable and the needy. We are fighting for them. And I've met times when we have catastrophic expenditure, people selling their land, their animals, so that they can be able to access care. And it really, breaks a healthcare provider when you have to send a patient home because they don't have money for a service that you can offer. So let us work together. Let us collaborate, even with the media, to ensure that our people are receiving quality, affordable, accessible quality care. Definitely, we will play our part where we need to, and I hope you do the same. Thank you so much, Health CS Dr. Deborah Barasa, for your time, and of course for answering some of the questions, not only ours, but equally Kenyans. We do appreciate your time. Thank you so much.
Asante sana. And that's how we shift focus to other stories.